So this is Dr. K Sahay. I'll be speaking about the role of fibrates, the current status in lipid management. At the outset, I would like to thank Dr. Mahapatra, Dr. PC Manoria, and Dr. Banerjee for inviting me to be in this prestigious meeting. We have heard a lot about the statins and the LDL cholesterol. So now we'll shift gears and discuss a little about the importance of triglycerides. How they contribute towards the atherosclerotic risk, and what is the importance of the various agents that are used for reducing triglycerides, particularly focusing on the fibrates. And does triglyceride lowering reduce the risk is the question that we're going to answer, and also discuss about the current place of fibrates in the management of lipid disorders. So if you look at the metabolism of triglycerides, we see that the two major, triglycerides are produced by the esterification of the free fatty acids in the liver and also in the enterocyte by the diacylglycerol transferase, acyl transferase, and then they are packaged along with the apolipoproteins to be released from the liver as the VLDL cholesterol and from the enterocyte as the chylomicrons. And if you look at the relative concentration of the various triglycerides in the various lipoprotein particles, you can see the size here depicts the percentage of triglycerides in each of these particles. And as you and the other important factor that I would like to enumerate here is the triglycerides potentiate the release of inflammatory cytokines and fibrinogen and interfere with the fibrinolysis process. Now, when you're looking at hypertriglyceridemia, the most important point that we have to keep in mind is that we need to exclude several secondary causes of hypertriglyceridemia, and they need to be treated not with fibrates but with correction of these underlying disorders. Like uncontrolled diabetes, very high sugar levels can be associated with hypertriglyceridemia, obesity, metabolic syndrome, alcohol consumption, acute pancreatitis, hypothyroidism, nephrotic syndrome. So all these conditions need to be treated, and there could be several drugs which could contribute to hypertriglyceridemia, particularly steroids and protease inhibitors or retinoic acid. And these need to be addressed. These issues need to be addressed before we start treating hypertriglyceridemia. And the other important aspect that needs to be understood is that hypertriglyceridemia, apart from indicating that there are atherogenic lipid particles which are in circulation, it also indicates it also leads to a change in the relative composition of the LDL from a phenotype A to a phenotype B. As you can see on the right side of the picture, you can see that there is a clear depiction of the increase in phenotype B, where there is increase in small dense LDL, which is more atherogenic, and similarly even the triglyceride enriched HDL particles may be less effective in terms of carrying out the reverse cholesterol transport. And if you look at the problem in South Asian Indians, we tend to have a genetic predisposition for having a greater degree of cardiovascular disease, and we see that we have a central obesity, increased insulin resistance, increased production of the atherogenic dyslipidemia, which with high triglycerides, low LDL, low HDL, and normal to slightly elevated LDL levels. If this is exemplified in the ICMR NDIVE study, which looked at diabetic subjects across the country, and amongst these 2,000 odd individuals with diabetes, we see that almost 90% of them had lipid abnormalities. 72, the major component being low HDL cholesterol being present in 72%, hypertriglyceridemia and 25.5%, almost 30%, and high LDL being present only in about 12% of the diabetics. So this exemplifies the importance of hypertriglyceridemia and also low HDL cholesterol levels. And this is again seen, several other studies also have shown that there is a high triglyceride level with low HDL cholesterol, which characterizes the dyslipidemia in Indian diabetic patients. And this is characterized by a central obesity, accompanied by central obesity, increased insulin resistance, and low levels of HDL cholesterol. And if you look at the definitions of the hypertriglyceridemia, this has been defined by the NCP ATP3 by way back in 2001, and the same holds true where normal triglyceride levels are less than 150. But the Lipid Association of India has recently gone ahead in their recent guideline published in November 2020. They have added this optimal level of less than 100 as the optimal level for triglycerides. And as you can see, higher triglycerides are linear. There's a linear association between the triglyceride levels and CVD mortality and total mortality in several different studies. As you can see in this study, also the different quintiles of triglycerides were clearly associated with increasing cardiovascular disease and mortality. The triglycerides and other studies like this Copenhagen City Heart Study and the Copenhagen General Population Study have also shown that there is a linear association between triglycerides and cardiovascular morbidity and mortality. And even if you look at the DAL outcome study and the miracle study, what is important here is that with low levels of, when the LDL levels are brought under control, even to levels of the levels that we are speaking of today, we are seeing that there is a residual risk, and the triglycerides are contributing significantly to this residual risk, and the increasing levels of triglycerides contribute to the increasing mortality amongst these cardiovascular disease amongst these individuals with or without LDL levels being normal. As you can see here, with LDL levels, irrespective of the LDL level, the higher triglyceride contributed towards the increased cardiovascular risk. Now, looking at this is another interesting study from the bisafibrate infarction prevention study, which also showed that over 22 years of follow-up amongst these 22,000 odd subjects, that the risk of mortality was clearly related to the increasing triglyceride levels. So there was 68% higher mortality amongst those with high triglyceride as compared to those with normal triglyceride levels. So then we move on to looking at the Strong Heart study, which looked at type 2 diabetic individuals amongst the American Indians. There again, you could see that there was a strong association of the triglycerides with both the cardiovascular disease and ischemic stroke. And this was associated with about almost 1.5 fold greater risk of hazard for CHD, and high triglyceride combined with low HDL was associated with the increased incident risk of cardiovascular disease and ischemic strokes. Now, coming to management of hypertriglyceridemia, the important issues that we need to look at is that lifestyle intervention is very important, and looking at the secondary causes. These are two important things that have to be looked at. This has to be underlined again. And then we have fibrates, which are very effective in terms of reducing the risk by almost about 35 to 50%. Then we have niacin, we have omega-3 fatty acids, we have got statins and ezetimibe. If you look at the fibrates, their main mechanism of action is acting through the PPAR alpha receptors, where they stimulate the PPAR alpha receptors and lead to not only reduction in the triglyceride levels, but also elevation in the HDL cholesterol levels and increase the synthesis of ApoA1 and ApoA2. Amongst the fibrates, we see that fenofibrate is amongst the more potent fibrate, which has less of the other problems associated with myalgias, and others are lesser with the fenofibrate, and the lipid lowering capabilities to the tune of about 20 to 35% of reduction in triglycerides and HDL reduction, HDL elevation by about 6 to 18%. And the other important factor that has to be kept in mind is, particularly with the older fibrates, there was this risk of renal dose reduction required in renal failure, but that is much lesser with fenofibrate. The other important aspect is that they have got several other effects which are seen beyond lipid lowering, as are listed out here. I'll not go into details of that, but what I would like to highlight is that there was effects on the vessel wall seen in terms of improvement in the nitric oxide levels, vascular, and also in terms of the heart. There is protection from the detrimental effects of high glucose and high and reperfusion injury that happens at the myocyte level, cardiac myocyte levels, and also a benefit in retinopathy shown not only in the field trial, but also another Taiwanese study has also shown that there is a clear reduction in the retinopathy. Now, does a reduction of triglyceride reduce the cardiovascular risk? We have a meta-analysis of these 5 important studies which has shown that there is a clear reduction, particularly in those with triglyceride more than 204 and HDL cholesterol less than 34. In this subgroup of patients, definitely there is a clear reduction in the cardiovascular disease and cardiovascular mortality. This was the field study, which I'll not go into details of. The field study looked at the primary endpoint was reduction in the cardiovascular disease and cardiovascular deaths, and there was the primary endpoint did not meet significance with the use of fenofibrate to reduce the triglyceride levels. No clear CV benefit was shown, but when they looked at the analysis amongst patients with high triglyceride levels and when they were combined with low HDL levels, there was a reduction of 23% and 27% in the mortality. Similarly, the Accord study also, while the primary outcome was not met with in the entire group of patients who were treated with simvastatin and fenofibrate, but in the subgroup which had low HDL and high triglycerides, there was a clear 31% benefit in the CV risk reduction. And the other important trial that has to be highlighted is this trial has clearly shown the benefit in terms of reduction in the cardiovascular. The primary endpoint was met in this trial, clearly showing that this molecule has a benefit, and but it has to be given 2 grams of this has to be given twice a day. And so we have seen from all this that that triglyceride reduction is beneficial, particularly in those with triglyceride levels which are higher. Now, what do the current guidelines say? If you look at the various guidelines, like the European guidelines, which speak of lifestyle changes first, and then look at using fibrates in addition to statin therapy when the triglyceride levels are more than 150, and using the IPE when the levels are in the range of 135 to 139 and more than 200, they advocate the use of fibrates. Now, you look at the more recent AAC, American Association of Clinical Endocrinologists. Again, they speak of looking at all these lifestyle factors, optimization of these factors, excluding secondary causes, and then using therapies like the IPE for triglyceride levels more than 135, and consider using fibrates or niacin when the levels are remaining higher than 150, even with the statin IPE regime. So this is how they have recommended. And even if you look at our own Lipid Association of India guideline, again, the role of fibrates is particularly when the goal is after appropriately correcting the LDL levels. If there is still higher triglyceride levels, then they recommend the use of fibrates. Thank you all for the patient hearing.